Okay, good afternoon, everybody. I'm Dr. Swaleha Mujawar, and today we'll be discussing the new drug Endoxifen, which is used primarily in the treatment of bipolar disorders. So, let us just look at the unmet needs which are present in bipolar disorders. Uh, Looking at the treatment, only lithium was available in 1970s when it was approved by the FDA for treatment of mania. After that, divalproate, carbamazepine, oxcarbazepine, and a lot of atypical antipsychotics were also used for management of bipolar disorder. So these are all the drugs which are available for the treatment of mania, hypomania, and mixed episodes. But there are a few challenges with these drugs. These challenges, which were seen in this national survey, one of the biggest challenge was finding the right treatment. Like 70% of the patients, they agreed that finding the treatment was difficult. 54% of them were tried on five or more drugs before the correct treatment could be established, and 17% were tried on more than 10 types of medication before the treatment was established. And of course, there are a lot of side effects which come with each and every drug. The commonest of the side effects are weight gain, anxiety, and drowsiness or sleepiness. And then there is also the economic burden of bipolar disorder. So there are direct and indirect costs that the patient has to bear with. Indirect costs like unemployment, mortality, non-healthcare losses, productivity losses. So both types of costs are also to be borne by the patient of bipolar disorders. So that is why there was a need for a new drug development. This new drug was aimed to reduce the challenges which were there with previous drugs and also bring a therapeutically relevant biochemical target. So traditionally, the drugs which were discovered by chance. They had some common features towards these symptoms, and the response was there at a specific synaptic activity. So research was done, and it was found that platelet protein kinase C, this was increased in bipolar disorder, and changes in this particular enzyme was used as an illness specific marker in bipolar mania. And that is why then drugs were developed which were focused at this protein kinase C. So, what is protease kinase C? Going back to the basics, biochemistry. Protein kinase C is present in the presynaptic membrane, as can be seen in this diagram. If there is increased activity, then there is increased release of neurotransmitters. So, your dopamine, norepinephrine, all these neurotransmitters are released in the synapse, and because of this overactivity in the neuron, symptoms of mania develop. So this is what is happening at the biochemical level. Protein kinase C, three types or three subfamilies are there: classical, novel, and atypical. The classical PKC, which is there, is present in the frontolimbic structures like prefrontal cortex, hippocampus, and amygdala. And due to changes in these areas, short term there is neurotransmitter release, but medium term some receptor regulation also occurs, and in long term cell proliferation, synaptic remodeling, gene expression, and then changes in neuroplasticity are also seen. And these are the changes which occur in bipolar disorder. But apart from bipolar, PKC also plays a role in substance use, cognitive, and suicidal risk. So it increases the risk of suicide. Excessive activation leads to cognitive impairment. Sometimes inhibitors are useful in reducing ethanol consumption and anxiety also, as is seen in some studies. And also PKC inhibition can be used in cocaine, cannabis, and morphine use disorders also. So these are the other uses of PKC also. Then again, research is being done that it may be useful in dementia, ADHD, impulsivity, borderline personality disorders, and sometimes schizophrenia or schizoaffective disorders also. So it has a wide range. And today we'll be focusing only on endoxifen and its role and development. So it was developed as a direct PKC inhibitor. So it is the first direct PKC inhibitor. It was seen that lithium and divalproate are indirect PKC, but this, because it acts directly, it is much more potent and lesser side effects also. And it is approved by the FDA for treatment of mania and mixed episodes of bipolar 1 disorder. So again, like we've seen in the previous slide, if PKC is inhibited, then all the neurotransmitters which were released excessively in the synapse, they are not released, and this is how endoxifen helps in reduction of severity of symptoms. And also because it is a direct inhibitor, it is a faster mechanism of action also. It stands out because it has higher potency, and it being a metabolite of tamoxifen, drug metabolizing enzymes like CYP450 and CYP2D6. This has a lesser effect. It is not dependent on all these enzymes. Looking at the pharmacokinetics of it, it has a linear pharmacokinetic profile, that is, the concentration increases with increase in dose. The plus point is this has a very long half-life of 52 to 52 to 58 hours. So this has a very long half-life. Now, let us look at the clinical evidence which is there for endoxifen. A lot of trials have been done. One phase 3 trial was done, which compared it with our gold standard divalproate, which we give in most mania patients. So, 116 patients were started on endoxifen and 112 on divalproate, and this was a randomized control. So, randomly patients were assigned. Out of them, a few dropped out, but 110 of on endoxifen and 103 on divalproate were evaluated. And what was found was that endoxifen was non-inferior. Non-inferior means it had the same effect as divalproate, and there was no treatment emergent depression. So they measured the YMRS, and there was improvement in YMRS all subscales. So language, thought disorder, insight, and content, a lot of improvement was seen from baseline. Now, this was to see the response and remission rate according to the day. So, day 2 responders were there, day 4 and 7 responders were also more compared to divalproate. So, what they want to say is there is an early response and remission with endoxifen compared to divalproate. Then again, there was improvement in disease severity as was measured, and also there was improvement in MADRS score also. So depressive symptoms also improved with this. As you can see here, compared to divalproate, the MADRS scores have also been shown here. Some side effects were seen in these studies. Commonly observed were insomnia, headache, gastritis, restlessness, and vomiting. Majority of them were mild to moderate. There were no deaths, no serious side effects which were found in the trial. Now, again, we know that divalproex has a lot of metabolic side effects. So when we compare the metabolic side effects like weight gain, blood glucose, and HDL cholesterol, there was no changes on, there were no metabolic side effects found. There were no changes in thyroid hormone levels also compared to divalproate. So endoxifen does not have all these side effects which were seen with divalproate. Now, endoxifen, especially safety profile in females, was of concern because it was a metabolite of tamoxifen, which has anti-estrogenic properties. But endoxifen at 8 mg dose was very low, so this low dose was not enough to mimic the estrogen-related activity, and adverse events related to female reproductive system were not reported because this was very low dose. The endoxifen dose, which was given in anti-cancer drug, was some 1600 milligrams. So 8 was very, very low dose. Now, if we want to start a patient, should we start it as a monotherapy, as a combination? So let us see if we can give it with benzodiazepines, what was found. So combination treatment was definitely superior. uh, Guidelines like CanMat, IPS, and Bipolar, all of them say that combination is definitely superior because 50% patients respond to monotherapy and 20% more patients will respond if we add on a benzodiazepine. So apart from monotherapy, it can also be used in combination with other mood stabilizers, atypical antipsychotics, and benzodiazepines. Now coming to the maintenance therapy, can we give it as a long term? Again, CanMat says that all bipolar disorder patients will require some maintenance treatment so that they don't have further episodes or some residual symptoms should be reduced with these, and also for quality of life. So generally medications which we give in acute phase, they are the same which are continued in maintenance phase also. So, yes, endoxifen also can be used as a maintenance therapy because it has benefits of tolerability. Efficacy also was seen with this, and real world experiences, which we'll be seeing in the case reports that I'll be discussing. So, case reports were also quite encouraging. So, what are these real world settings, or what are the cases which were there? So first case report of endoxifen treatment for this was used for a year. So there was a 49-year-old woman with history of hypothyroidism and thalassemia mania minor with also bipolar mood disorder of 10 years duration. She had history of multiple depressive episodes also and manic episodes. She was tried on multiple drugs: olanzapine, desvenlafaxine, fluoxetine, risperidone, aripiprazole, but she developed side effects with most of them like weight gain and sedation with olanzapine, irregular menses with risperidone, and agitation with aripiprazole. So because of this, she was unable to function. There was a lot of distress, and family was also starting to lose hope. And in April 2021, she presented again with a manic episode. And at this time of presentation, she was on treatment. She was taking 10 mg of olanzapine with fluoxetine and desvenlafaxine. So, first and foremost, both the antidepressants were stopped immediately, and she was started on endoxifen 8 mg once a day. Olanzapine dose was reduced to 5 mg and then gradually stopped. So at baseline, her YMRS score was 25, MADRS score was 11, BPRS score was 72. After 3 months, it was on endoxifen therapy. It was seen that her YMRS score reduced from 25 to 5. MADRS score was 1. BPRS was also 32. So there was significant reduction in all the scales. And even after a year, this reduction was there, and there was no relapse, no side effects. So this was a very encouraging case report. And a lot of other case reports are also being done, like endoxifen. Can it be used for uh, more than 6 months, which is usually the maintenance? So one of the data showed that more than 2 months, 62% patients tolerated and continued with this drug, and 17 and 21% for 6 months and 3 months. There was a case study in Ames also. So this was a 35-year-old married male with having bipolar mood disorder 1 for the past 16 years, who was on follow-up also since 2017. The current episode was subacute, again of irritable mood, decreased need for sleep. So again, a manic episode was there. At the time of admission, patient was on multiple drugs, clozapine 350, lithium 1200, rifaximin 1000 mg, lactulose because there was raised ammonia. L-carnitine was also added due to increased CPK levels, and levothyroxine. So because of the rising CPK and ammonia levels, we thought of the case report thought of further increase in dose was not possible. So that is why they thought that let us add endoxifen and see the results. So endoxifen 8 mg in combination with clozapine 350 and lithium 1200 was given. And you can see at baseline the score was 38. After 3 weeks, the score came down to 11. So there was significant reduction. And because there was improvement, endoxifen was stopped. But after stopping, again the score went up to 32. So it was restarted again. And after on week 7.5, score was 10. At 10th week, score had improved and was reduced to even 8. So almost complete remission of manic symptoms was there, and this patient is still on regular follow-up. Then another study by another case report by Dubey was done, and this was to show the long-term effectiveness and the hospital stay, uh, how it is decreased by endoxifen. So again, a patient was admitted, and day 2 endoxifen was started, and by day 5, day 6, there was significant decrease in YMRS score from 36 to 13, and the score was so low that the patient had reached euthymia, and then the patient could be discharged also. So the hospital stay was also decreased. Patient was discharged in a week, unlike other what we see. And also there was a decrease in craving of alcohol also seen in this patient. Then another study was there. This showed the number of pills which were reduced. So we know a lot of times bipolar mood disorder patients require more than one medication, sometimes a long list. So this patient had total of 17 tablets, and from that it was reduced to 7 tablets after adding endoxifen, and also the YMRS score was also reduced. So even though we were reducing the medication, but the YMRS score was also being reduced. And then finally, at the end of 6 and 8 months, the patient was on only 2 tablets, endoxifen and risperidone, and the YMRS score was also significantly reduced to 4. So again, this is very encouraging for us to see. And also the hookah and the shisha smoking by the patient was also reduced. So again, a add-on benefit. So all these studies mostly had patients of bipolar mood disorder. This was a case series of schizoaffective disorder. So a 36-year-old male and 41-year-old female. These patients were diagnosed with schizoaffective disorder, and they were not getting better with the conventional medicines. So that is why endoxifen was added. And again, as you can see, the BPRS score and YMRS score both decreased with medication, and at the end of 4 and 7 months, there was a significant reduction. Uh, Last case report which we'll see, this was of a healthcare professional. This is not her photo, this is just for illustrative purposes. But a healthcare professional could not perform surgeries due to tremors with lithium and had developed hyperammonemia with valproate. So, what was the patient? The patient was the patient of bipolar disorder with severe mania, with also delusions and suspiciousness. YMRS score at baseline was 41. BPRS score at baseline was 44. So again, lithium did not work, valproate did not work due to the side effects. So endoxifen was added, 8 mg OD along with paliperidone 150 mg, the long-acting injection which is given monthly. So both these medicines were started in the patient, and definite improvement was seen at day 3 or at third follow-up. BPRS score was 22. At fourth follow-up at 47 days, YMRS score was 0 and BPRS score was 18. And again, the fifth follow-up was again after approximately a month. Again, the YMRS score was 0 with BPRS score of 18. So definite improvement was seen in this patient also. So the healthcare professional could go back and resume the work also. The only concern for us is the cost effectiveness. So compared to lithium, olanzapine, yes, endoxifen is expensive. So this was a analysis in which the medication cost was compared. So see, lithium and olanzapine will cost around 1950. If we add valproate also along with paliperidone, the cost can go up to 26,000 for 20 days. And if we add endoxifen along with paliperidone, the cost goes up to around 50,000, which is quite a lot. But if we look at the hospitalization cost, that is more with lithium olanzapine, the investigation cost, and also sometimes mania patients have spending spree, so excessive spending by the patient also. So if we look at all these other costs, definitely then endoxifen along with paliperidone seemed like a cheaper option. And more than 1 lakh prescriptions have been given to bipolar patients of endoxifen. So definitely that is something which we have to keep in mind and we can use. So uh, from a tamoxifen point of view, it is seen that it is a metabolite of tamoxifen, which is actually a selective estrogen modulator. So this is given as an anti-cancer drug and in breast cancer patients. But endoxifen at 8 mg dose does not mimic this activity and does not have this anti-cancer effect. And in breast cancer also, the studies which are done, they say that very high doses are given. In bipolar, it is not significant, and the doses are not comparable also. And also, it is a metabolite, but it is a different metabolite from tamoxifen, because one metabolite, alpha sulfoxy metabolite, was there which used to cause uterine cancer in patients who were given tamoxifen. But because endoxifen is a metabolite itself and this metabolite is not involved here, so again the risk of uterine cancer is not seen in patients if we give endoxifen. Then again, depression is anecdotally associated with tamoxifen in patients who were given these for breast cancer treatment basically. But it is not reported in healthy women which were given tamoxifen, and again, very less chances with endoxifen also. And the phase 3 trials which were done with endoxifen again did not show any emergent depression or treatment emergent depression. So just to summarize, it is a it acts on protein kinase. The first line drugs which we use are currently lithium and valproate, and endoxifen being a direct PKC inhibitor. is or should be preferred because lithium and valproate are indirect inhibitors. It does not require therapeutic drug monitoring, does not require dose titration. It has a very long half-life of around 50 hours. Does not require hepatic enzymes conversion also because it is a metabolite in itself. So that is why there is improved safety, decreased variability, and also decreased interaction with other drugs. And specifically in acute mania, it had comparable changes in YMRS and MADRS scores. There was improvement in YMRS scores. Significant reduction from baseline was seen. Significant reduction in MADRS scores were also seen. An earlier response was seen compared to divalproate. Divalproate had almost 14 days before response was seen, but with endoxifen, a response was seen in day 2 and day 4 also. And safety and tolerability, no suicidal behavior was reported, thyroid was not increased, somnolence and sedation was not there. Metabolic side effects was also not there, so weight gain and cholesterol levels were uh, not not basically there were no significant changes, so there's no improvement, but there's no side effect also. There's lower incidence of abdominal pain, and of course, none of the trials showed any deaths or any serious side effects with this. So with this, I end this. Thank you so much for listening.